right, hello and welcome everyone. This is Caleb from the National Rural Health Resource Center and the task team. Today we have a chronic obstructive pulmonary disease, or COPD, prevalence and impact webinar, and we're really excited about the webinar to share with flex coordinators, critical access hospitals, and rural health clinics some of the important things going on with COPD in rural America. The prevalence and impact is where we're focusing today's webinar. We hope to have you as participants discover the scope and scale of COPD matters in rural America, understand the personal impact of COPD, as well as learn about the national initiatives and the Federal Office of Rural Health policy efforts, and hear an example of one state's efforts that are already underway related to COPD. Joining us, we have Christy Martinson, Director, Hospital State Division from the Federal Office of Rural Health Policy, Grace Ann Dorney-Koppel from the Dorney-Koppel Foundation, as well as the COPD Foundation, and Lynette Johnston from the Pennsylvania State Office of Rural Health. She's the Quality Improvement Coordinator at the Pennsylvania Office of Rural Health. And we'll start out with some of the efforts underway in the task office at the National Rural Health Resource Center, and then we'll transition to hear from Christy at the federal office to hear about some of the initiatives nationwide and from the federal office, and why the federal office sees such an importance in this topic. And then we'll hear from Grace Ann Dorney-Koppel, who will discuss some of the scope and scale of COPD matters in rural America. And then Lynette Johnston will discuss some of the state examples of efforts and the personal side of COPD. And then we will open it up for questions and discussions toward the end. All lines are muted by default to preserve the audio quality of the recording. Star 2 will unmute your line when you have a question. In the meantime, please utilize the chat feature to the left should you have any questions or comments as the webinar goes. Please take a moment to complete the polling questions initially here in the beginning, so we have an idea of where you as our participants started with knowledge, and then we'll have some closed out polling questions at the end as well. This webinar will be recorded, and recording will be posted on the TASC and National Rural Health Resource Center website shortly after the completion of the webinar. Terry Hill and myself are the primary people at the National Rural Health Resource Center task team who are responsible for the COPD efforts. So if you have any questions, comments, or have anything further to contribute to the discussion, please don't hesitate to reach out to either Terry or myself. All right, so a fair amount of the task, so the task rural COPD activities. First, a quick disclaimer first, the National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities as the nation's leading technical assistance and knowledge center in rural health. The center focuses on 5 core areas: the transition to value and population health, collaboration and partnership, performance improvement, health information technology, and workforce issues. The efforts in regards to COPD at the National Rural Health Resource Center are posted here on the slide. So we're working on a rural technical assistance manual to be released in August of 2019, and that will be directed toward flex coordinators and rural providers, critical access hospitals and provider-based rural health clinics. And it will focus on the importance of the issues of COPD, what ideas, what can be done regarding implementation of services, how you may implement services at a critical access hospital, the things you want to keep in mind, how to ensure that you're providing up to standard care, where to find those resources, things of that matter. This is the first of 2 webinars focused on COPD. And today's webinar is focused on the prevalence and impact of COPD in rural America. And June 11th will be our second webinar, and that'll focus a bit more on the financial side of it. We do know and understand that you cannot just expand services at a critical access hospital or a clinic without being able to cover the expenses of those costs. So there are billing and coding discussions that need to be thought about, making sure you have an adequate patient population to cover the costs of expanding care, or how to address those things. We are also working on a podcast series, and at least Grace Ann has participated as one of our podcast guests, and we'll have a varied participant list from Grace Ann, with her role as the president of the Dorney Koppel Foundation, as well as a patient of COPD. And we'll have providers on there, and hope to have critical access hospital CEOs to discuss kind of the whole gambit of COPD in rural America, the importance of it, and how it affects all of us, really. And then we'll have a little more information on this, but we're working on an assessment of rural hospital COPD services. So we really want to find out what's working well, what struggles are there, so we can help provide additional adequate resources moving forward, both for the hospitals as well as flex coordinators, so that you as a flex coordinator are able to provide adequate, relevant technical assistance to your hospital. We at the National Rural Health Resource Center have a host of resources, but we want to draw your attention to resources from some of our partner organizations. This slide deck, as well as the others, can be downloaded in the bottom left file share area, and these links are live as well. So RHI Hub is a partner organization that has a bunch of COPD resources, as well as NORC and Rural Health Resource. So please take a moment to familiarize yourself with the resources and where to find those national. And as I said, myself and Terry Hill are probably your best sources of contact at the Center for COPD efforts, but anyone at the center will be able to connect you with Terry or myself. And next, we will hear from Christy Martinson, the Director, Hospital State Division at the Federal Office of Rural Health Policy, and she's going to talk to us a little bit about the perspective from the Federal Office of Rural Health Policy and how they see things. Christy, are you there?
I am. Can you hear me?
I can. Thank you very much for joining us.
Thank you, Caleb. And I appreciate the opportunity to sit on this panel. I'm actually here on behalf of Dr. Paul Moore, who's my colleague in the office who has been leading the effort around COPD for our office, working closely with Grace Ann Dorney Koppel from the Koppel Foundation. They've been a key partner in our philanthropy work over the years, and so we're really excited to continue the efforts and partnering with them specifically around the COPD work that we're kind of enhancing now in our office. So I'll just give a little bit of background on how our office has gotten involved more directly with COPD in recent years. We were engaged through NIH and the work that they had done on the National COPD Action Plan. They reached out to our office to see what we could do to specifically look at COPD in rural areas, just given the prevalence rate in rural areas that's higher in urban, and also the more pronounced mortality rates in metropolitan counties than in metropolitan counties. So because it is significant issue in rural, seeing what we could do as an office and more broadly with our colleagues in the federal government and outside partners to really look at this from a rural issue standpoint. So we, through our National Advisory Committee on Rural Health and Human Services, had a meeting in September in North Carolina where a subgroup looked specifically at COPD issues to come up with recommendations that we could provide to the Secretary. But before I get into those recommendations, I just wanted to highlight what the National Action Plan goals were for the kind of broader NIH plan that you can see here. So kind of taking it from a patient perspective, looking at it from the provider perspective, from a data and public health data approach, as well as data and research, and then how we can take all that information and translate it to improve research and public health care actions around COPD across the board. So from the committee's perspective on the National Advisory Committee, what are the specific things that we should be thinking about from the rural provider perspective? So one of the recommendations was to educate rural primary care providers and individuals with COPD about the rural disparities and focus on what are things that we can do to make improvements in that area. So the task work that Caleb just mentioned is one area where we're working to try to provide some resources to help hospitals and providers understand what are ways that they might be able to take action in this area. Another key area that the committee identified is around the prospective payment rates and how they are potentially lower than they might need, lower than the actual cost now. So looking at, how is pulmonary rehab reimbursed versus, say, cardiac rehab, which gets reimbursed at twice the rate. So that's, from a policy perspective, nothing that we can do within our office, but raising the question of, is the care being provided being reimbursed at a rate that's kind of significant? And then the third recommendation is to look at this direct supervision issue to make sure that providers in rural areas who aren't always at that physician level, but looking at physician's assistants and nurse practitioners who are able to provide care of pulmonary rehab, to make sure that regulations are in line and allow those providers to operate efficiently within the context of the rural environment of care. So again, this is not something that we can take action on just within our own office, but putting these recommendations to the Secretary to look at from the perspective of HHS. So finally, COPD activities within FLEX. I won't get into this information since Caleb already covered that under his slides, and we really appreciate the work that he and Terry and the rest of the task team have taken to really delve into this issue in 2019, and we look forward to all the resources that are going to come out, starting with this wonderful webinar. So now I will turn it over to the other great speakers that we have on the call who can really share their experiences and resources around COPD.
Great. Thank you, Christy. We will transition to Grace Ann Dorney-Koppel, the president of the Dorney-Koppel Foundation, as well as a board of directors member of the COPD Foundation.
Well, good afternoon to all of you. I really am very, very grateful to the National Office of Rural Health Policy and as well to TASC and to the CDC and to the NHLBI for bringing this issue forward and focusing on the devastating effect that COPD is having in rural America. Until recently, until the last year and a half, I don't think it's been recognized. However, HRSA had a wonderful workshop last June. We did have meetings in conjunction with the COPD National Action Plan, and it is being discussed. But it was curious to me when you displayed the slides before the webinar as to how confident people are in their knowledge of COPD. And I hope that after today's webinar, at least I'll have scratched the surface to make you aware what a serious problem it is in rural America. So I am a COPD patient. I was going along with life quite well until middle age arrived. I felt I was healthy. My doctors told me I was in excellent health. I'm an attorney, a behavioral scientist, a mother, a grandmother, an educator, and life was really looking good. However, there came a time in 2001 where I had difficulty breathing and walking at the same time, breathing and dressing, breathing and showering. So I went early to my primary care doctor and was given every test, but not a breathing test, and was told if I lost a little weight, I might feel better. I literally collapsed just a few weeks later. I couldn't sleep. I had pillows propped up behind my back. I had extreme shortness of breath. I was coughing and wheezing. Life really was not good. Fortunately, I was diagnosed. I took all my medical records and went to a hospital center. And the first test they gave me was a breathing test. It's called spirometry. And at that point, I was diagnosed with very severe COPD, chronic obstructive pulmonary disease. And I had lost 75% of my lung function. The prognosis was grim. I was not expected to survive any longer than 3 to 5 years. However, I was given the most important thing, and that was a prescription for pulmonary rehab, which was available within a half hour of my home. And that program, which combines education, knowledge about the disease, recognition of when you're getting a lung attack after a respiratory infection, and support, because you're in a group setting and there are other people who are dealing with the same disease that you are. That program of 10 weeks, twice a week, changed my life. I began exercising. I used my medications properly because I was shown how to do it. I developed a knowledge about the disease that's continued. I've continued to keep up with it. I read the journals. I've learned, and I know my enemy, my disease. And as a result of that, my husband and I, realizing that this treatment, pulmonary rehabilitation, was not widely available anywhere, but hardly available at all in rural America, began finding good foundation partners, and there are now 12 Grace Ann Dorney pulmonary rehabilitation clinics, and 11 of those 12 are in rural America because that's where the need is the greatest. So actually this diagnosis, as grim as it was, changed my life and has made it possible for my husband and I, by finding great partners, to make it available to people who need it most. Today, I still have COPD. It's not curable. It's a progressive disease. But I have learned how to manage my disease so that I can continue to work full-time. And I have a mission now. My life has been altered in a good way by this disease because I'm hoping that it will bring a path for others to follow. So this is a photo. I am the second on the right. When we opened 3 clinics on the same day in rural West Virginia, one at Boone Memorial, which is a critical access hospital in Madison, West Virginia, another at New River, which is a federally qualified health center, also in West Virginia, and a third at Cabin Creek, also an FQHC in West Virginia. And left to right, there is Kim Teenan, who is a representative of the Benedum Foundation, our partner. Next to Kim is Cecil Roberts, the president of the United Mine Workers of America. In the center is Jay Rockefeller. He and his wife Sharon also contributed to this. And to my right is my husband. So it takes a community effort in order to address this disease. And these were clinics 2, 3, and 4. The first clinic was in our home state of Maryland at St. Mary's Hospital in Leonardtown, Maryland. And here in the center, I am again surrounded by some patients, respiratory therapists, our partner again directly in back of me, my husband to her left. And this is in Ripley, West Virginia. This was one of our more recent clinics. And the next clinic in line is also in West Virginia, not too far from Morgantown in rural America at Preston Memorial, which is also a critical access hospital. COPD is a public health epidemic. It's not really been recognized as such. But when we look at deaths, we see 2015 through 2016, 154,596 in 2016. Well, in 2017, the numbers are not here, but it's 160,000 plus, a significant difference. The numbers of dead of this disease are rising, and the death certificates do not capture all of them because it may in fact say a comorbidity of COPD rather than COPD. The costs of COPD are staggering. $32 billion direct, $49 billion by 2020, and this does not include any of the indirect costs, nor does it begin to capture the personal burden of the disease. The most present statistics in terms of how many have been diagnosed is roughly 16 million, and an equal number is thought to have the disease but not be diagnosed. And I want you to pay particular attention to the last bullet. Rural populations had the greatest risk in 2015, twice that of urban, and we will get into that. So this is really the headline for today. When we talk about disparities, when we think that in urban America, and it's not that the rates are great in urban America, but they are twice what they are in rural America, and we have to do something about it. I do want to just briefly touch on what it is. It's preventable, it is treatable, and if you come away with one thought, it should be that could we diagnose earlier, that would be the greatest blessing. But for the millions who live with COPD now, it is treatable. The treatments are there, and we have to be sure that they're available in rural America. So we see a normal airway, but we look next to it in bronchitis. We see a lot of mucus, swelling, and restricted airflow. So the umbrella that encompasses COPD is really two main conditions. One is chronic bronchitis, and the other is emphysema. In emphysema, the smallest cells that the airways lead to have been permanently damaged, so that the air that we breathe in that contains oxygen that's supposed to get through to our cells and remove carbon dioxide, those exchange areas have been damaged permanently. And because it is a progressive disease, it will only get worse as we age, because all of us lose some lung function as we age. And let's start with risk factors. You will see in the center upper part of the screen a family. Certainly there are genetic components to who is susceptible to risks of COPD. We have one clearly identified risk population. They're called alpha-1 because they lack a protein that's needed. And a blood test, a simple blood test, once you're diagnosed with COPD, can identify you. But COPD actually starts in the womb. It starts earlier in prenatal development. So if our mothers smoked, or if we were in an adverse environment, a lot of smoke and particles and gases and dust, if our lungs never developed fully because we were a preterm baby, those are all risks that we start out, some of us, at the very beginning of life. And as we progress into childhood, if we have asthma, we're more likely to develop COPD in adulthood. If we have a lot of childhood infections, again, the same. If our nutrition in childhood is not good, that's also a risk factor. And again, the pollutants, the secondhand smoke, the environmental exposures during our lifetime will mean that our lungs really never develop to the stage that they should. And our lungs, by the time that we are 20 to 25 years old, have reached their maximum ability in development. Then as we move on in life, if we are exposed to more pollutants, outdoor and indoor, if we ourselves smoke, the disease is more likely to occur. I did say rural populations have a greater risk factor, and why is that? Well, tobacco use is much higher in rural America than it is in urban America. There's greater exposure for prenatal as well as childhood exposure to secondhand smoke, and less access to smoking cessation programs. And environmentally, the vapors, dust, mold spores, organic toxic dust, smoke from burning biomass fuels exist. Other factors, of course, are respiratory infections, the asthma history, and then as we get older, and those of us who are old and poor suffer the most. So again, focusing on risk factors, worldwide indoor air pollution is considered to be the major factor, and in the United States, smoking. This map shows cigarette use among U.S. adults, and you'll see the highest range, the darkest colors, 22.9% to 26.4%, are clustered in the area that is adjacent to the Ohio and Mississippi rivers and in the southern part of the United States. And this is a National Geographic clipping from February of 2015. In many sections of our country, indoor heating is primarily based on fossil fuels, on coal or wood or coke. There is exposure in air pollution and burning of trash and things like that. I don't believe you could see this map but Caleb tells me that he will make it available afterwards. This is from the Journal of Environmental Health Perspectives, 2014. It may shock you to know that solid fuel, wood, coal, and coke, is the primary heating source for 2.5 million U.S. households, 6.5 million people. And now we get serious. Age-adjusted death rates for the 5 leading causes of death. I should have earlier thanked both the NIH, National Heart, Lung, Blood, and the Center for Disease Control for making this data available, because until we had this in 1971, this is from the CDC, we did not realize the enormous gap that existed between COPD in rural America and in urban America. So I hope you can see these slides. These are the 5 leading causes of death. Of the chronic diseases, heart disease is number 1, cancer number 2, chronic lower respiratory disease, which is the way the CDC categorizes COPD, is number 3. I want you to notice that for all of these chronic diseases, including stroke, the direction between metro and urban, it's going in the right direction. It's going downward. They're reducing. The numbers are reducing. The lines are growing closer together and in the right direction. However, for COPD, you will notice this gap between urban and rural. It is increasing in rural, but has sort of stabilized in urban. And this other category, which I hope you can read, is accidental death. Accidental death includes everything from falls, auto accidents, deaths by fire, and opioid deaths. The reason that COPD dropped from the 3rd leading cause of death to the 4th leading cause of death is because of this combined category. There are about 70,000 opioid deaths, and they have increased this accidental death category. But note that among chronic diseases, COPD is still number 3 and significantly more than what it was in prior years. And this is just an overview of COPD in the U.S. Again, I want to point your attention to these areas in red and orange. Looks very much like the smoking map, does it not? Because, again, it's along the Ohio and Mississippi River. It's in the south. And you'll see states like West Virginia, 12.3% of the population is diagnosed with COPD. But then when you look at California, it's 4.7%. You think, my, that's not so bad. That represents 1.3 million people. So it's important to have this big picture and then to look at some of the disparities, again from the CDC. The question is raised, why do some rural counties in the Midwest and the Great Plains have low prevalence of doctor-diagnosed COPD? You see they are in the lightest color, 3.2 to 6% of the population. Well, the answer is they have very high death rates. So early diagnosis and treatment comes too late. And here really is the stunning statistic that I led my slides with. The age-adjusted prevalence doctor-diagnosed COPD among people older than 18 years old by urban-rural status. Urban is in black, rural in red. You can see that in large metro centers, 4.7 of people have COPD. Look at micropolitan and rural and see that 8%. That is the data from the CDC published in 2018 that really got all our attention. And the death rates. For COPD in general, we know that there were 160,000 deaths in 2017. But here, an age-adjusted death rate per 100,000 with COPD as the underlying cause of death. You can see in a large metro center, and these are in 100,000 of U.S. population, 32. And look, it's 54.5 in rural, 52.8 in micropolitan. Again, hospital discharges where COPD is listed as the first diagnosis. Medicare enrollees aged 65 years and older. You see, again, rural and micropolitan lead the way in the wrong direction. And this is shocking new data. It was published in November of 2018, and I thank Dr. Meredith McCormick, who was one of the authors of this Rural Residence and Poverty, as independent risk factors for COPD in the United States. I want you to particularly note the dark bar is here that they are showing that although we know it's 8.4% nationwide, the highest prevalence is 15.7% if you are rural and poor. So what we have is a graph of non-poor, which is the light blue, and dark blue, which is poor. And this remains true even among never smokers, people who never smoke but are rural and poor. And again, we associate the level of coal for heating, for fuel, with COPD prevalence. So there are a lot of gaps. One gap is on the patient side, the other is on the provider side. Adults with COPD in 2016, only 73 talked to their doctors about their symptoms, and only 40% were given a breathing test, which is spirometry. It's a simple test. You exhale as hard and as long as you can into a tube, and the machine plots that graph. So patients don't tell. Maybe they don't know that the coughing, the shortness of breath, the reduction in activities, the wheezing is not normal. Maybe they think they're just getting older. But we have to sensitize the population to this. And doctors, only 71% evaluate with a breathing test. And 68% acknowledge that pulmonary rehab programs are available. And of those that acknowledge it, only 38% prescribe it. We have three major treatments for COPD. We have inhaled medicines. We've not had a new one in 20 to 30 years. We have oxygen, but only if your oxygen in your blood is low enough at rest. And we have pulmonary rehab. But look at this map. This is from the CDC, unpublished. Access to pulmonary rehab is very scarce, and there will soon be a paper by Dr. Ira Moskovitz on availability of pulmonary rehab in rural America, and it is not available. I want to thank Christy because she talked about the National Action Plan, so I will skip past this. But there are roles for all of us, roles for patients, for government agencies, for doctors, for payers, and we've got to get this information out to rural America. And I will end much as I began by pointing out that is 8.2% of diagnosed rural Americans with COPD. Translates to 3.5 million people. And hundreds of thousands, probably an equal number, who have the disease and don't know it. So it's really up to all of us, and I truly thank TASC and the Federal Office of Rural Health Policy, the National Health Institute, for bringing this to your attention, because it will take all of us to create a path with answers for this problem. And I'd like to end by quoting from a very famous Chinese philosopher. Hope is like a path in the countryside. At first, there is no path. But if enough people walk in the same direction, the path appears. And that's what I believe we are doing and what I hope will happen. Thank you.
Thank you very much, Grace Ann. And next, as we load up Lynette's slides, we will hear from Lynette Johnston from the Pennsylvania Office of Rural Health. Lynette is the Quality Improvement Coordinator with Pennsylvania Office of Rural Health. Lynette, are you there? *2 will unmute your line.
Hi, Caleb. Yes, I am here, and I would like to first thank Grace Ann so very much for her wonderful presentation and all of her diligent work that she is doing to help with the efforts to reduce COPD and all the detrimental effects that it has. And Grace Ann, you sound as wonderful as Lisa Davis described you to me. So thank you for everything that you shared. Grace Ann did, she gave a lot of the same information that I'm going to be going through. So Caleb, to save time, we can skip over the COPD facts because Grace Ann did a very thorough job covering those. So if you can just go through them, that would be great. So the reason that I really want to talk about this, because as everyone knows, I am a Flex coordinator for the Pennsylvania Office of Rural Health. And while completing the Flex grant for the last 2 years, I really found out how the Flex program coordinators play an integral part of assisting the rural constituents in the areas that they serve. The Flex coordinators do a lot of work to help provide evidence-based material to our critical access hospitals, our rural health clinics, and other providers to ensure not only that we are getting effective care, but the care is also high quality care. So I really think that that's important, and the Flex coordinators do a wonderful job with that. Caleb, are you going to go to, okay, perfect. So currently I am on the COPD panel for the National Office of Rural Health, and we are implementing a COPD manual. And what our goal is to do is to, number one, help people who have COPD, help train clinicians and other healthcare providers on how to effectively manage COPD. And we really need to have this information distributed across the country. As Grace Ann strongly suggested, and she is so correct, the approach needs to be a multidisciplinary approach. It needs a team. People need to come together to help combat COPD and help diminish the incidence of COPD. So as a Flex coordinator, I think that we can work together and distribute the COPD manual to all the CAWs, the rural health clinics, and also other rural providers. So the COPD's manual, the purpose is to raise awareness of COPD and most importantly, to assist COPD patients and clinicians with maximizing optimal patient outcomes. The COPD manual is in alignment with the national COPD action goals. And as you can see, the COPD action goals, the national COPD action goals are listed here, and they are to empower people with COPD, to improve the diagnosis, the prevention and treatment, and the management of COPD, collect, analyze, and report data regarding COPD, and to increase and sustain research to better understand the prevention, pathogenesis, diagnosis, treatment, and the management of COPD, and to translate national policy, educational, and program recommendations into research and public health care actions. So again, as Grace Ann mentioned earlier in her presentation, it is a multidisciplinary approach, and we really need to work together as a team. As an esteemed Flex coordinator, you can help diminish the COPD crisis in the United States through sharing the COPD manual, and you can make a difference one breath at a time. What we're doing here in Pennsylvania, we assist all the critical access hospitals with the implementation of a robust COPD educational folder for their patients. We have discussions with the CAW leaders and quality improvement directors of the Center for Medicare and Medicaid COPD Initiatives and Goals. And Pennsylvania is also in collaboration with the esteemed Pennsylvania Department of Health to assist CAWs in the prevention and management of activities for COPD. And I'd just like to share a patient's perspective. Grace Ann was very willing to share her story. I would like to share with you my story with my 40-year-old brother who has COPD. His past medical history, post-traumatic stress disorder, alcohol abuse, tobacco use since the age of 16, 1 pack per day for 24 years, depression, anxiety, familial tendency, which is shaking of the hands, that's a genetic inheritance, and polypharmacy. He's currently taking over 17 medications for his COPD. He has more than 60 hospitalizations within 5 years. 4 of those admissions were to drug and alcohol rehabilitation centers. And this, folks, I'm sure you've heard of the high utilizers. This is a high utilizer patient. And my brother did give me full disclosure to share his information, and he said I could use his name, but I said I'm not going to do that. But he did give me full disclosure. But a little bit of background about my brother. He was a prominent person in the community. He started off by graduating from the police academy. He served on the police academy for a long time. He went into the military. He served our country for 10 years. He had numerous tours to Kosovo, Iraq, and after doing that, it really hurt him. He saw things that the typical person doesn't see every day. When he came back from the Army, he had post-traumatic stress disorder, but he didn't give up. He became a railroad engineer for the largest railroad company in the United States. But he's still battling this battle. So you can go to the next slide. So I asked him what it was like to have COPD, and I'm sure, Grace Ann, you could relate to this. He said to me, "Sis, I hope you never have to know or experience. It's pure hell on earth. 1 minute you feel fine, and the next minute it feels like someone's taking a syringe and sucking all the air out of your lungs." And he says when that happens, it creates a significant chest pressure and pain. And he said it feels like your brain is always in constant stupor because you lack the oxygen that the body needs. And that nicotine is extremely addicting. And you know, he is working with his team. He's now down to a half a pack a day. He was at 1 pack. Now he's down to a half a pack. And he just recently was discharged from a 3-day admission because he couldn't breathe. You can go there. Okay. So from a provider's perspective, I did graduate from family nurse practitioner school, and I'm getting ready to sit for my board. But while doing my internship, I had the privilege to work with a large COPD patient population. It was a privilege because they taught me so much as a provider. They taught me what it's like, how you need to treat the COPD patient. And it's again, as Grace Ann said, it's multifactorial. You need to take in all the aspects of the patient. Whenever you were working with them, there's an elaborate systematic approach that you need to do to treat the disease. You have to treat, some of these patients have a dual diagnosis where they suffer from anxiety and depression, just the fear and anxiety that the patients have because they can't breathe. You need to have a very slow approach in taking your time with these patients, because when they're answering your questions, it takes them a very long time to get the words out. They become short of breath just by talking. So you really need to approach it delicately and gingerly. And also, too, when you're working with your patients, when you're talking to the flex coordinators, when you're out there talking to the providers, they recognize that, we need to really talk to our patients in layman's terms. Not all the patients can understand the medical jargon. And we need to offer options for them for quitting smoking, offering different medication and education on, for example, how to properly use an inhaler, because if you're not using the inhaler correctly, that can produce a lot of detrimental effects. And there's also other non-medicinal ways to handle the stress. And another approach is that we offer expert consultation for our patients who require medicinal approaches to treat the anxiety and depression management. And we utilize the motivational interviewing technique to educate and to empower the COPD patient, and most importantly, always remain non-judgmental. I can't tell you how many times I would be in the emergency room with my brother, and certain clinicians were quick to say, well, he still smokes, and I piped up and would say, look, he's my brother, I'm a patient advocate, and I'm not going to judge patients who have COPD for whatever reason. They have the disease either because, they were exposed to environmental exposures, or they have genetic preconditions that they were born with, or that they were a smoker. Regardless, we need to take care of these patients in the best empathetic approach in a non-judgmental way. So I really think that as a flex coordinator, we can help this. As Grace Ann said, we need to come together as a team, and we can do this. Any questions for me?
Thank you very much, Lynette, Grace, and Christy. Star 2 will unmute your line if you have any questions for any of our speakers. Please utilize the chat feature. We heard 3 different perspectives, all of whom were great, and discussed some of the efforts currently underway, some of the important things, the data that's going on, and I think if nothing else, we have a much better understanding of the importance of addressing or treating or making efforts in COPD care in rural America. As we said, we'll have another webinar in June on the 11th, and that'll focus a little bit more on the business side of it for providers, clinics and hospitals, the billing and coding options that are available. The manual will be released the end of